The next topic that I'd like to delve into is that of drug disposition. You may hear this term, drug disposition, in different textbooks as you read for this class and others. And what drug disposition is referring to is all processes that are involved in the absorption, distribution, metabolism, and elimination of drugs. So drug disposition really is going to cover many diverse areas within pharmacokinetics. Let's begin our discussion talking about what's happening once the drug gets absorbed. And if we look at this this part of the page, I've tried to depict for you drug absorption from left to right. Right, drugs coming into the systemic circulation. Maybe it's coming across the intestinal membrane after being given orally and dissolving, disintegrating, and being absorbed across the intestinal tract. Maybe the drug's being absorbed into the systemic circulation through a topical administration on the skin or through an injection into a blood vessel, intravenous injection, for example. So the drug has been absorbed, and we'll spend some time talking about absorption in the slides that come later. But for the moment, what's going to happen now once the drug has been absorbed? Okay, this rectangle would depict the systemic circulation. And as we can see, the drug, when it enters the systemic circulation, can undergo many different fates. Right? Many things can happen. One of the things that can happen to that drug once it gets into the systemic circulation is that it may or may not bind to plasma proteins. And the most commonly encountered plasma proteins that can bind drugs are those such as albumin, are those such as alpha-1 acidic glycoprotein. Okay, and these are plasma proteins which float around in the plasma component of our blood and possess an ability to bind to certain drugs. Now, if you think back to Chapter 1, we mentioned albumin as an interesting site in the body for drugs. And we mentioned it in the context of being something called an inert binding site. And so when a drug binds to a plasma protein such as albumin, there is no conformational change that occurs. There's no activation of a receptor that occurs. There is no cellular response that occurs. But rather, the drug is bound to the plasma protein, and there's not as much of it now to go to other places. Okay, so the plasma protein is acting as a type of sequestering protein. It's binding some of the drug. And I want you to notice that in most of these depictions, the arrows go in both directions. That means the drug can bind and it can dissociate. It can bind and it can dissociate. And we'll do it in an equilibrium manner. So in the case where a free drug binds to plasma protein, there's less of it to be able to do other things, such as, if we now look towards the top of this illustration, such as leave the systemic circulation and enter tissues. Now, for the purpose of this discussion, I want you to consider the blood as a separate entity from the tissue into which the blood runs or perfuses. Now, it's true that if you take a liver and you look at the liver, there's blood inside the liver. Okay, but what I'd like you to think about in terms of the drug leaving the blood and entering the tissue is actually leaving out through the blood vessel walls, diffusing across them, and entering into the parenchymal of the tissue, right? So we're talking about the liver, leaving the blood vessels in the liver and entering the hepatocytes, or entering the Kupffer cells, or the different types of cells in the liver. I would consider that the extravascular tissue, right? So in the liver you have the vascular tissue, which would be all the blood vessels, and the extravascular tissue outside of the blood vessels, the region outside, which would be all the other cells that make up that particular organ. Okay, so when we think about tissues and organs, we should think of them as the blood and the rest, right? Or the vascular space and the extravascular space. Right, so when the free drug leaves the systemic circulation, which is part of the vascular space, it can go into the parenchymal tissues and bind to receptors. And so as you can see, we have the free drug being able to enter into tissues and to bind receptors. Of course, unless we're talking about irreversible antagonists or such, that binding will be reversible. The arrows will go in two directions. Right, so the drug can leave the circulation, bind to its receptor, eventually fall off its receptor, and eventually come back into the circulation. Now, once it comes back into the circulation, other things can happen. It can sometimes directly be excreted from the systemic circulation. But this usually isn't the case, because usually the drug, if it got into the body and got into the tissues, is usually hydrophobic in some capacity. Now, talking in general terms, because there's always the exception of carrier proteins. But if the drug got in, that's usually a problem for the drug getting out. Okay, but some drugs are going to directly be excreted into urine. They're going to be polar enough, and they're going to stay in the watery urine. But most drugs, when they get back into the systemic circulation, will be taken to the liver and will be metabolized before they're excreted. Okay, so the whole topic of Chapter 4, which will be the chapter we talk about in our next lecture, when we meet again as a class, will be the metabolism side of things, and I'll get into a lot more detail about that. But for the moment, let's think of this as elimination, and elimination can include metabolism, and does include excretion. Excretion where? Into either the bile, which eventually ends up in the feces, or into the urine. And gets eliminated from the body. Well, actually, before we go there, before we move on, there's a few other things that can happen to the free drug in the systemic circulation. So if we look again at the free drug, we've talked about plasma protein binding, we've talked about receptor binding in tissues, we've talked about excretion and the role metabolism can play. But one thing that I haven't yet mentioned is, in some instances, a drug can accumulate in a tissue reservoir. Right? A reservoir, as you know, is a huge body of water that serves as a common drinking, water for common drinking in a community. And tissue reservoirs would be something similar, where a drug can preferentially accumulate and, in that regard, be removed from systemic circulation, but not yet eliminated. And where do we see tissue reservoirs? We see them in bone tissue, in fat tissue. Very different types of drugs accumulate in these different reservoirs. For example, in bone, ions such as lead or certain types of tetracycline antibiotics can accumulate there and be released at a later time into the body. We think about this in terms of tetracyclines because during bone formation, tetracyclines could actually cause discoloration of bone. Some people who've taken tetracyclines, for example, get discoloration of their teeth. If they took that antibiotic during a time where the bone was forming. Okay. On the other hand, there's fat tissue that can act as a tissue reservoir, and this is usually going to attract very hydrophobic compounds, compounds such as thiopental or organochlorine compounds, which are very to the whole class of pesticides. These agents can accumulate in fat and can stay there, and as you burn your fat, now you're exercising and the fat's being burned, those drugs can be released again into the systemic circulation. Okay, so these are the many possible fates of the drug once it achieves entry into the systemic circulation. And so just to review, the drug can come into the systemic circulation. It can potentially bind to plasma proteins. Do all drugs bind to plasma proteins? No. But there are many drugs that do. Drugs such as digoxin, phenytoin, a very high percentage of the dose will bind to plasma proteins. Drugs will move out of the systemic circulation if they need to bind to their target receptors and target tissues. They can come back into the systemic circulation once they dissociate from that receptor, at which point they can be metabolized and then excreted. in some instances, drugs can accumulate in tissue reservoirs. Okay, so when you think about what's happening to that drug, which has been administered, these are all of the different possibilities that may be occurring. Right, so very important to realize that the drug must be absorbed and distributed to its target so that it can reach its receptor. But there's a chance that it may also reach other regions, such as the tissue reservoirs or other tissues where the drug might have adverse effects or at a minimum, just prevent some of the drug from reaching its target. When we think about this ADME and its relevance to therapeutics, very relevant in the context of helping the clinician determine how rapidly and how long a drug is going to be able to function and to activate or block its intended receptor. And a very important concept within pharmacokinetics is, the standard dose of a drug, which has been developed through many years of drug testing and using healthy volunteers who generally have an average ability to absorb and to distribute and to eliminate drugs. Right? Sometimes that standard dose, which has been developed by the companies that develop the drugs, isn't always going to be working in patients. Or in some instances may be working, too extensively and entering the toxic range. So, for example, there may be sensitive subpopulations in which a dose has to be altered, such as in infants. Right? Little infants don't have a matured kidney. They don't have a matured liver, at least not on the same degree as a young, healthy adult. And so oftentimes the dose is going to have to be reduced when given to an infant. If you go into a pharmacy and you look at the children's formulation of Tylenol, for example, you'll see it's a much lower dose than the extra strength given to adults. So infants are a special subpopulation to consider when when administering a drug. And another important condition will be a disease state. If a patient has heart failure and their heart's not pumping the blood as efficiently as it otherwise would, then the blood's not moving through tissues as good as it otherwise would, then it's not getting to the kidneys as efficiently as it otherwise would to be filtered and removed. Okay, so disease states such as heart failure, renal failure, other types of diseases may have a significant impact on a drug's pharmacokinetics. into. Let's first talk about absorption. And absorption really is the challenge of a drug getting across the membrane. Remember, the membrane has a hydrophobic core, and that hydrophobic core, that lipid bilayer that has that hydrophobic core, is going to serve as a barrier to polar drugs. So how are those polar drugs going to get absorbed? And here we can see an example of the outside of the cell. This triangle-shaped structure would represent a polar drug, and it's trying to get into the cell. How can it get into the cell? Well, it's usually going to have some kind of transmembrane protein, sometimes called a carrier protein, that's going to bring it in if it needs to get in. And the drug's going to therefore bind. There'll be some conformational change that brings it inside. Now, these carrier proteins can act in the absence of any kind of energy, and in that regard, the process would be called facilitated diffusion. Diffusion is just being helped along by the protein. On the other hand, if this carrier protein needs to use energy, such as ATP, that process is called active transport. Okay, so if we're now talking about drugs diffusing in, either they're going to have a carrier protein that may or may not need energy to function and bring the drug in, or they'll simply diffuse in through lipid diffusion across membranes. Now, remember, the diffusion of drugs across membranes is going to be subjected to Fick's law and to the Henderson-Hasselbalch equation. So if we look over here on the right, we see an example of a weak acid where in the stomach pH, which would be around 2, the relationship or the equation favors the protonated form, right? The arrow goes to the left. The weak acid in a very acidic environment doesn't need to donate another proton because the environment's very acidic already. So that protonated weak acid, which is also known as a neutral compound, can be absorbed across the membrane. Now again, most of the absorption of drugs isn't happening across the stomach membranes, but rather across the membranes of the small intestine. But for the sake of argument, absorption of that drug across the membrane in the neutral form, now the drug's in the body, and it may now enter the plasma. And in the plasma, let's say the pH is around 7, 7.2. That weak acid is all of a sudden going to be able to donate its proton, and you see the arrow favoring the ionized form. Drug may now be trapped in the plasma. Okay, so I bring this up here because this is an illustration of how the absorption of a drug can be affected by the pH in which it finds itself. Thirdly, we need to consider special sites in the body that can pose a challenge to absorption, such as in the brain. In the brain, there's a blood-brain barrier where there are specialized tight junctions, and those specialized tight junctions can prevent passive diffusion of most drugs from the systemic to the cerebral circulation. In fact, in order for a drug to get across the blood-brain barrier, in general, it must be hydrophobic, or if it's not hydrophobic or nonpolar, it's going to need some kind of carrier protein or transport protein to bring it in. Now, in males, there's another site within the body where there are these types of tight junctions, and it's often referred to the the blood-testis barrier. That shouldn't say brain-testis barrier. It should say blood-testis barrier. And in that case also, drug needs to be hydrophobic to be able to cross in, with the exception that it may have a transport protein to bring it in. Okay, so it's interesting that the body has developed this kind of defense mechanism to protect the areas of consciousness and of reproduction, which tend to be vital to our survival as the human race. So I'm going to pause here and just see how this presentation is going in terms of size. If it gets too large, I'm going to have to break it up into smaller files. So let's see how we're doing. Now, in terms of absorption, one thing that I didn't mention from the last slide was that many of these carrier proteins can be considered or can be classified into groups called OCTs and OATs. And you'll see that on the last page. I just can't go back because I'll lose everything I just said and have to repeat it all again. But if you look at the oats and the ox, these are going to be organic cation transporters and organic anion transporters, right? And there are many different types of these ox and oats. They're found on the basolateral side. I'm sorry, on the luminal side of the intestinal epithelial cells. So some drugs are going to be well absorbed across these oats and ox into cells and put back into the systemic, or put into the systemic circulation. Another place where these drugs, where these transporters, these oats and these ox are found, commonly found, is in the kidney, particularly on the proximal tubule and on the distal tubule. Okay, so what I want you to know about oats and ox is that these are different types of transporters that can bring in, diverse types of cations and anions, and in that way help those charged polar molecules circumvent the plasma membrane. Not all drugs are going to be substrates for oats and ox, but many will be. All right, now getting to this slide. Bioavailability. This is an important definition. This is going to be the fraction of a drug which is absorbed. Okay, the fraction of a drug which is absorbed. The way to measure bioavailability is to just administer the drug and look to see what its concentration is in the blood over time. Okay, so remember, the definition of bioavailability is the fraction of drug which is absorbed systemically. The fraction of drug which is absorbed systemically. So write that word up here, systemically. The fraction of drug which is absorbed systemically. So if the fraction is 1, that means 100% of the administered dose was absorbed systemically. So one way to guarantee a fraction of 1, and if you multiply that by 100%, a 100% bioavailability, the way to ensure that is to administer the drug intravenously. And that would be this situation, right? The curve here where at time 0, all of the drug was deposited into the blood, by doing an IV injection. And as what you can see, as time goes by on the x-axis, right, following the injection, the amount of drug in the blood starts to decrease, right, in an exponential decline. And the area under that curve would be the number to use for the AOC of total systemic absorption. Okay, so that would be the denominator of the fraction above. It would be the area under the curve of the drug administered via intravenous injection. Okay, the denominator of that curve, it says AUC of drug administered. It should say the area under the curve of drug administered via IV. And the numerator of that fraction should say the AOC of drug that's reaching the systemic circulation. Maybe the drug was given orally, as you can see here in these two different scenarios. Right? In one scenario, a drug was given orally, and the area under the curve was about 50% that of the area under the curve for when the drug was administered systemically. Right? So what I'm hoping you're seeing here is that the area under the curve tells you how much of the dose was absorbed into the systemic circulation. So in the example where you have 50% bioavailability, there's less of the dose absorbed than in this example where almost 100% of the dose was absorbed through oral administration or subcutaneous or intramuscular. Right, so again, bioavailability is going to be the area of the curve, area under the curve of the drug that has reached the systemic circulation by the route of administration that was used. The denominator is the area under the curve of the drug administered via intravenous injection. And so an intravenous injection is going to give you a 100% bioavailability, while administration of drug through other routes will give you a bioavailability that may be less than, or in some cases equal to 100%. And if you get bioavailability that's less than 100%, it means the drug was incompletely absorbed. Maybe there was food in the stomach that affected its absorption. Maybe it was degraded in the stomach by a protease. But something happened that led to the drug being incompletely absorbed. And to build upon this idea, perhaps the drug underwent what's called first-pass metabolism. And we talked a lot about first-pass metabolism in the lecture today. That's when the absorbed drug that got across the intestinal membranes and got into the blood was brought first to the liver and eliminated before it, metabolized and eliminated before it could get to the rest of the circulation. Okay. Now, the next topic to discuss is how is the drug distributing, right? How is it moving through the body? How is it, getting into the blood and then getting into its target tissues? By definition, distribution is going to be the process by which a drug diffuses or is transferred from the intravascular to the extravascular space, right? So from inside the blood vessels to outside the blood vessels and into tissues. And so, of course, in order to have distribution, you have to have some degree of absorption. The drug has to get into the systemic so that it can now distribute into the rest of the body. So let me try to illustrate this by using a few different types of graphs that the textbook uses. Let's imagine a situation where we're in the very upper graph where the arrow is pointing, and this is a hypothetical situation where there's no elimination of the drug. So the drug was administered, it distributed, there was a rapid increase into the tissue into which it was administered, that was the blood, but there's no elimination, so the levels of drug in the blood, the y-axis, they stay the same over time. There's no way for the drug to get out, there's nowhere else for the drug to go. This is a hypothetical situation, this is not reality. But that's what it would look like. The drug would be absorbed, it would distribute into the blood very quickly, and it would plateau. It wouldn't be able to move in or out. It would just be contained within the blood. Now let's go to the second graph, where we're looking at the concentration of drug in the blood on the y-axis versus time on the x. And here's a situation where the drug can now distribute into the extravascular space. So it got into the systemic circulation, and now it's going into tissues, into parenchyma. And as you can see, the drug rapidly got into the blood, and there's a distribution phase, a slow exponential decline, into which now the drug was able to distribute into those extravascular tissues. Right? So first the drug got into the blood, but then some of it distributed out into the tissues. This is almost reality. This is almost what, a typical drug's distribution into the blood and tissues would look like. But there is no port of exit in this drawing. There is no elimination phase. Right? So now if we look at the third graph, this would be a scenario where there can be no distribution into tissues, but there can be elimination. Right? So, and again, it doesn't exist this way, but just for the point of argument, if you administer the drug will rapidly distribute into the tissue and then will eliminate because there's a port of exit. And, I said tissue, but I meant blood. So let's say that again. In this graph, if you administer the drug will accumulate in the blood. It has nowhere to go because the way we're setting up the example, it can't distribute. We're just saying that it's not possible to distribute into other tissues. And so it will start to be eliminated. While the last graph on the panel is more like reality. So the drug will be administered, it will absorb into the systemic circulation, there'll be a slow, a steep exponential distribution phase, followed by a slower exponential elimination phase. This is the kind of graph you see for most drugs. Drug is administered, it distributes, and it gets eliminated. Okay, but depending on certain drugs, depending on certain tissues, the elimination kinetics, right, how the drug is eliminated over time, the shape of the graph might change. But for most drugs, it looks something like this. Drug is administered, it distributes in a steep exponential decline, followed by a slow exponential decline of elimination. Right, so that scenario would be the drug getting in the blood, moving into the extravascular space, and also being eliminated. Now, one principle to keep in mind, referring to drugs' ability to move through the body, is its ability to move through water. If you look at body water makes up about 75% of the total body weight of a lean animal, where that number can fall to about 45% of the total body weight in a fat or obese animal, and this would include humans. So in a very lean, athletic physique, about 75% of that person's body weight is made up of water. In a more obese body type, that can drop to about 45%. And that's actually a very large difference. Right now, at present, the average total body water, is about 60% in people across the United States. Right? So the ability of a drug to dissolve into water means that it might go where the total body water is. Right? If a drug has a good ability to dissolve in water, it's going to like to go where the body water is, with a few exceptions or with a few corollaries to that statement. First of all, where is the body water? Well, if you look at total body water, the majority of it is found inside cells, the intracellular fluid. Other areas in the body that contain water would include the interstitial fluid, the blood plasma, and the transcellular fluid. Okay, so these are going to be different regions within the body, or different compartments that are composed of water. And if a patient's taking a drug which is water soluble, then the drug may end up in one or more of these regions. For example, if you look at small water-soluble molecules such as ethanol, and I apologize for the misspelling there, but it should be ethanol. But if you look at a small water-soluble molecule like ethanol, this will distribute through all body water, right? Through the plasma, the transcellular fluid, the interstitial fluid, the intracellular fluid. Ethanol is able to move with the water in those areas. On the other hand, there are certain large molecules that are water-soluble, such as mannitol, which is an osmotic agent. This is going to be too big to get into smaller water compartments, so it's going to be localized to the extracellular water. If you look at the blood plasma, okay, which is composed of water, you'll see highly plasma protein-bound molecules there, very large molecules, and highly charged molecules, such as, for example, heparin. While if you look at fat, and fat's made up of mostly fat and a little bit of water, you'll see the lipid-soluble molecules, but the very lipid-soluble molecules, things like diazepam, are going to potentially accumulate. Whereas in bone, which also is minimally composed of water, other drugs such as lead, tetracyclines can accumulate. One very important factor in the ability of a drug to enter into a tissue or to be eliminated through a tissue is going to be how much blood gets to that tissue to bring the drug there. And so what you have before you is a table that kind of compares the different major organs in the body in terms of their blood flow, in terms of their organ mass, how big is the organ, and in terms of a normalized ratio of blood flow to organ mass. Now, organs are going to vary in their capacity to take up different drugs. And so if we look at something like the liver or the kidneys, and we look at the normalized blood flow per kilogram of tissue, you're seeing very large numbers, 680 milliliters per minute per kilogram of liver tissue, 3,333 milliliters per minute per kilogram of kidney tissue. Right? That's a lot of blood coming into those different tissues per unit time. And so the blood is what's first bringing the drug to those areas. If there's a lot of blood getting to those areas, there's a lot of chance for drug to diffuse out of the blood in those areas into the tissues, or conversely, for drugs to be eliminated in those areas. And so, if you look at liver and kidney and their normalized blood flow, and you compare it now to something like fat tissue or adipose tissue, what do you see? You see that the blood flow to fat is much less, per kilogram of tissue than it is to the liver or the kidneys. That has a serious complication, or I guess it's not complicated, but a serious ramification associated with it. And what that ramification is that drugs are going to take longer to accumulate in fat than they would, for example, in the liver or the kidneys. Because the liver and the kidneys are so highly perfused that there's a good chance that the drug, if it's there and is able to accumulate, will do so. While in the fat is poorly perfused. Right? The fat is a poorly perfused tissue. So it's going to take longer for the drug to accumulate there. But because it's poorly perfused, the drug will stay there longer than it would in a place such as the liver or the kidneys. You see, the drug's going to take longer to accumulate there, but it's also going to take longer to leave that tissue. That's one of the reasons why many people fail drug tests, because they'll take illegal drugs, and those drugs may be hydrophobic enough to accumulate in fat, and it's been 3 months, and they were really nervous before their interview and their drug test, and they started to burn that fat that contained the drug, and now all of a sudden the drug's been detected in the systemic circulation. Why? Because it takes time for the drug to accumulate in that poorly perfused tissue, and it takes time for the drug to be removed from that poorly perfused tissue. The next topic that I'd like to discuss is that of the VD, which also is known as the volume of distribution, and is sometimes also called the apparent volume of distribution. The reason why it's called apparent is because in some cases the volume is so large that it exceeds any true volume within the body. In fact, what this really is a fingerprint about a drug. It tells you really the ability of the drug to move into the extravascular space with respect to the vascular space. So to calculate the volume of distribution, one would divide the administered dose by the concentration of drug that's been observed in the plasma. And one way to kind of depict this would be to look at the rectangle to the right. Oops. Oh man, I'm not going to be able to go back without re-recording it. So I'll just be talking about that last slide here, okay? And then I'll talk about this slide too. So if you look at that rectangle, you'll see that the drug is administered into a central area, that being the vasculature, the systemic circulation. And in the upper rectangle, it's all contained there, right? That would be considered to have a low volume of distribution because the dose that was administered is very similar to the dose that's in the blood. The drug didn't leave the blood. It didn't go into the extravascular spaces or the tissue parenchymal cells. On the other hand, if the dose of a drug is administered and the amount of drug found in the blood is low, that would suggest most of the drug left the blood and went into tissues. So drugs that have high volumes of distribution are those which are able to leave the blood very readily and enter into tissues. So now let's pick up with the next slide. Drugs with high volumes of distribution are going to be those such as amiodarone. Look at that volume, 4,620 liters in a 70 kilogram person. That's much larger than their true physical volume. And that's why it's called an apparent volume of distribution, because it's really just telling you how able that drug is able to leave the blood and enter into the extravascular space. Right? Drug like chloroquine, very high volume of distribution. What would you predict for drugs which are very poorly lipid soluble and don't have carrier proteins, like drugs like heparin? Would you predict that that drug is going to have a high volume of distribution, that it's going to be able to penetrate into different parenchymal cells of different tissues? No, but it doesn't need to, because it's working in the blood to thin the blood and prevent clots. Right? So the fact that a drug has a low volume of distribution may not necessarily mean it's ineffective. But on the other hand, if you need the drug to get into the brain, or if you need the drug to get into the eye cells, then a drug with a low volume of distribution is going to have difficulty accessing those sites. Okay, so what the volume of distribution tells you is the total volume you would need for the drug to be dissolved in a homogeneous concentration throughout that whole space. And if that's still not clear, then a simpler way to consider it is just the ratio of the drug that you gave to the concentration in the plasma. And the higher the volume of distribution, the less that's in the plasma, the more that must be outside of the plasma or in the extravascular space. Okay, since I advanced this slide before finishing what I wanted to say about the previous slide, I want you to still keep your eyes on that previous slide. Okay, how can you do that though? You don't have a copy, do you? Well, what I'll do is I will provide this as a Word file as well. And that way you'll have copies of all of these. Okay, anyway, there's one thing I wanted to talk about in terms of protein binding and drugs that get trapped in the blood or in the plasma. Now, if you look at those diagrams at the lower portion of the preceding page, you'll see that a drug that is bound to albumin or to some other kind of plasma protein, it cannot diffuse from the vascular space into the surrounding tissues. And so a drug that does not bind to plasma proteins very much is able to readily diffuse into tissues. And that's going to result in a high level of binding to the site of the pharmacologic action, usually at the receptor, and also in a high rate of elimination because the drug's going to be able to be readily cleared. And drugs that would be good examples of this would be drugs like acetaminophen or nicotine. However, on the other hand, drugs that exhibit very high levels of binding to plasma proteins are going to require higher plasma drug concentrations so that enough of it can become free to enter into tissues and bind to receptors. Okay, and examples of drugs like that are going to be drugs like amiodarone or warfarin. And again, plasma protein binding is one of several factors that is going to affect drugs distribution. But remember, these plasma proteins are acting as inert binding sites. So think about a situation where there's a disease state where now there's less albumin around than there was before, but the patient's still taking the same drug, while all of a sudden there's a lot more drug which can be cleared, and there's a lot more drug which can enter into tissues potentially. Okay, so plasma protein binding, although it's considered inert, definitely does affect the pharmacokinetics or contributes to the pharmacokinetics of the drug. I want to now turn to this slide, which we should be discussing, and focus on drug elimination. How's the drug going to be taken away from the body now? How's the body going to get rid of the drug? And there are majorly two ways. There are two major ways in which the drug will be eliminated. Usually through renal excretion into the urine, biliary excretion into the bile. First, let's talk about renal excretion. Okay, pictured for you on this slide is a cartoon sketch of the nephron, and the bean-shaped structure would be the glomerulus, through which drug can be filtered. Now, if a drug is highly protein bound, right, it won't be filtered through the glomerulus. It'll be stuck to the protein because the glomerulus won't let the protein into its lumen so that it can pass through the nephron and eventually go into the urine. No, the proteins are too large. But unbound drug can enter into the lumen through the glomerulus. So a few factors are going to affect renal excretion, things such as renal blood flow, things such as glomerular filtration, things such as drug binding to plasma proteins. Remember, only the unbound drug will get filtered. Now, once that drug enters the lumen and starts to move throughout the nephron, through the proximal tubule, the loop of Henle, the distal tubule, the collecting duct, different things can happen. So depending on if that drug which has entered into the lumen is polar or not polar, different things can happen. So in a situation where the drug is polar, the drug will enter through the lumen, will enter the glomerulus into the lumen, and eventually transfer through all the way down into the urine. In a case where a drug is nonpolar, there's a good chance that it's going to be reabsorbed before it enters the urine. Also, a little earlier today I mentioned the presence of OX and OATs, the organic cation transporters and the organic anion transporters. They are found, these types of transporters are found on the walls of the proximal tubule. Some evidence to suggest they're also found in the distal tubule. And some drugs will be secreted into the lumen of the nephron, such as, for example, penicillin, across these organic anion and organic cation transporters. Okay, so one way for the drug to get in is to be filtered into the glomerulus. Another possibility, if the drug happens to be a cation or an anion, may actually just directly be secreted through these OX and OATs. Right, so the drug is usually going to enter through the glomerulus. It's going to then, or potentially enter through the proximal tubule by tubular secretion. It's then going to keep on going, journeying down through the loop of Henle and the distal tubule. If the drug is very nonpolar, there's a chance that in the distal tubule it will be reabsorbed. That's called tubular reabsorption. If, however, the drug is polar, then it will be eliminated through the urine. Okay, so if we go back, most drugs are going to be filtered through the glomerulus, enter into the lumen of the nephron. Some drugs will be secreted through the OX and the OATs into the lumen of the nephron. As those drugs move, if they are nonpolar in nature, they may be reabsorbed through the distal tubule. On the other hand, if they're polar in nature, and maybe they're polar because they're anionic or cationic, or maybe they're polar because metabolism made them so, which will be the topic of Chapter 4, right? But if they're polar enough, they'll pass into the urine. Another way for drugs to leave the body is to be excreted into the bile from the liver, okay, through transporters. There's also OX and OATs on the walls of the biliary ducts. And so drugs can enter into the bile, be dumped into the small intestine, travel through the small and large intestine, and in some instances they can be reabsorbed in the large intestine. That situation in which the drug is dumped into the bile but then reabsorbed before being eliminated in the feces is called enterohepatic circulation. Entero meaning gut, hepatic meaning liver. The drug keeps going back and forth from the liver to the gut, from the gut to the liver, from the liver to the gut, from the gut to the liver. Enterohepatic circulation. There are many drugs that get stuck into this loop. Certain steroids, drugs like digoxin, some chemotherapeutic agents exhibit enterohepatic cycling, as do some vitamins. Now, eventually, enough cycles go by, and not all of the drug gets reabsorbed each time, so eventually the drug gets eliminated, but there's this loop of enterohepatic cycling that can occur. Let's turn our attention now to the elimination side. Okay, we talk about the liver and the kidneys as being sites of elimination, and pharmacokineticists have studied different parameters that are associated with elimination, one of them being clearance. Clearance is defined as the rate of elimination of a drug with respect to the concentration of the drug in the plasma. And clearance is going to be a volume per unit time. Clearance. How much blood is cleared of drug per unit time? Now, if we look at drug elimination and we plot it as a factor of the concentration of drug in the plasma, right, what you get is a hyperbolic function that has a Vmax, which would be the rate of maximum elimination, has a Km, which would be the half maximal rate of elimination, follows usually Michaelis-Menten kinetics. And what you can see is, as you get to very high concentration of drug, well above Km value, elimination becomes saturated. While at doses below the Km value, drug elimination is what's called first order. And because of that, the rate of elimination continues to increase as the concentration of the drug increases. Sometimes that situation is called flow-dependent elimination. As soon as the blood brings it to the liver, it starts to get eliminated. And nothing ever gets saturated. So you add more drug, the elimination increases. If we look at the plateau portion of the graph, some drugs are going to be administered at therapeutic doses where the rate of elimination is flat. It cannot change. It's not first order. And that would apply to certain drugs such as phenytoin, ethanol, aspirin. Right? If you have a flat line, a plateau, that's considered zero order. If you have an increasing hyperbolic function, that's considered first order. And usually for most drugs, the majority of drugs exhibit what's called first order elimination. It means you can't saturate the elimination. That, okay, you give more drug, the rate of elimination keeps going up. And most drugs are working down, well below, well down on the graph. But there are some drugs that will saturate the rate of elimination, drugs such as ethanol or phenytoin, right? And they have what's called zero order kinetics. Why am I talking about all of these things? The majority of drugs exhibit first order kinetics, and we're going to talk about something called half-life of the drug. While drugs that exhibit zero order kinetics, we can't really talk about half-life because half-life becomes irrelevant. It changes. It doesn't remain constant, and I'll show you that soon. One last thing to talk about is that tissues such as the liver and the kidney are able to extract drug, and pharmacokinetics is interested in knowing the extraction ratio for different drugs. And so the extraction ratio is just the concentration of drug before it gets to the organ compared to the concentration of drug when it leaves the organ, okay, divided by the total concentration of drug. And when we look, the liver has a very high extraction ratio for many drugs. It's one of the reasons why it's able to play a major role in first-pass metabolism for many drugs. Okay. While, for example, other tissues such as the lungs or the brain have much lower extraction. This brings us to the idea of the elimination half-life of a drug. And the elimination half-life of a drug, again, is going to be relevant for drugs which are following first-order elimination kinetics. And this can be defined as the amount of time that it's going to take for the drug concentration in the plasma to decrease to half of its original value. The amount of time that it's going to take for the drug concentration in the plasma to decrease to half of its original value. Sometimes this is abbreviated as T 1/2 for the half-life of a drug. Now, there's an equation that can be used to determine the half-life of a drug, and that's depicted for you here on the page as 0.693 times the volume of distribution divided by the clearance of a drug. And if you've noticed, I've drawn arrows to the volume of distribution and to the clearance. And I've done that because one can conclude, based on this relationship, that half-life is directly proportional to the volume of distribution and indirectly proportional to the clearance. Now, let's look at what this looks like in practice. On the left panel, you see a graph where the concentration of drug in the plasma is being monitored versus time. And two different doses have been administered. A high dose which is depicted by curve A, and a low dose, which is depicted by curve B. The drug undergoes first-order elimination kinetics. That means that the rate of elimination is not saturated, right? So the body can clear the drug and deal with the change in the dose. We're at levels well below saturation. And so the amount of time it takes to go from 8 to 4 is the same amount of time as it takes to go from 4 to 2. The half-life is the same even though the doses are different. And that's true in first-order elimination kinetics. On the right graph, if we look at the concentration of drug in the plasma on the y-axis as a function of time, and we give two different doses, and the drug's zero order, so maybe it's ethanol or phenytoin, what you see is the half-life for drug A is much different than the half-life for drug B. They're not the same, right? We're dealing with a situation where the rate of elimination is saturated, right? Clearance cannot compensate, and so half-life will be totally dependent on the dose, which is very different from the normal situation where drugs are in first-order elimination kinetics, where the half-life is constant. Now, if we look at volume of distribution, if we look at clearance, we see these are both involved in the drug's half-life. So factors that affect these parameters will affect the drug's half-life. For example, as people age, they tend to lose muscle mass. So there's less muscle mass for drugs to distribute into. Right? That can affect the half-life of a drug. Right? There's less of a volume of distribution. On the other hand, as people age, they tend to accumulate more body fat. So body fat or obesity can increase the volume of distribution and increase the drug's half-life, as can the accumulation of pathologic fluid into which drugs can distribute, such as ascites fluid in, for example, patients that are alcoholics that have liver disease. There are different factors that can affect the clearance of drugs. If P450s are induced, the clearance will be faster, the half-life will be less. If P450s are inhibited, the clearance will be slower, the half-life will be longer. Right? If a patient's got heart failure or hepatic failure or renal failure, the ability to clear those drugs is going to be decreased, and the half-lives are going to be longer than they otherwise would. And of course, this can affect, or this can lead to toxicity because, as we saw in class, half-life is linked, well, as an important parameter to keep in mind, so as to prevent too much drug from accumulating in the body. And of course, if you exceed what's called the therapeutic range of a drug, then you start to get into the toxic range, and can have toxic effects in patients. So hopefully these narrated slides gave you a little bit more information about things that will help you understand some of the variables, the pharmacokinetic variables of drugs. And please use this supplemental lecture to help you study for your midterm, in addition to the things we discussed today in class. Good luck, and if there are any questions, we can address them in office hours, or we can address them at the beginning of our next class next week.